We got about a minute till we'll start, or I guess about 10 seconds now, but while we start, if everyone can just keep themselves muted unless you guys have a question, and then you can unmute and interrupt me. I also need all of you guys to turn on your cameras and be in the view of the camera. And then can everyone hear me okay? You guys can just, yeah, nod. Yep, perfect. So we'll kind of start first with some housekeeping things. So I am Dr. Brooke Martin. You can call me Dr. Brooke or Dr. Martin, whatever you guys prefer. Professor Martin is fine as well. So I have worked in pediatrics a long time. Essentially my whole nursing career, I've worked with general peds. So in a hospital setting, I've worked with in a clinic setting as a nurse. I've worked with kids on pediatric hematology and oncology floor. And then now I'm currently a pediatric nurse practitioner in a rural health clinic in Iowa. So, and I've been a pediatric nurse practitioner now for about 3 years. And then I also taught some nursing clinicals. So I haven't done the lecturing side of things. So if you guys have any input, I would appreciate that as we go through. So if at any time you guys can't hear me, you can't see something on my screen, you guys can just interrupt me. And then when you interrupt me, just don't forget to go back on mute afterwards. So you guys have all been able to get into the course okay and find the modules and all of that? Okay. Have you guys all done your first initial post in the discussion? Okay, and that all went okay? Okay, did we all also do a citation? You did, because there was 2 sections of the question, like tell us about yourself and then let's talk about nutrition. So if you didn't add a citation going forward, I would definitely like that to be there for each discussion post. And then when you respond back to others, it's helpful to add that in a citation as well. And don't just say like, I enjoy what you posted, you know, expand on that a little bit too. Another thing is, so you guys can get 2 10-minute breaks, or we can kind of go all the way through. Which would you guys prefer? And then get out a little early.
I vote early.
Go all the way through.
Okay, is everyone okay with that?
Yeah.
Okay, perfect. That is what we will plan on doing then. Okay, so first we'll start off. I'm gonna try to share my screen here. Okay. Let's see here. Okay, so we'll first start with, and then also, sorry. Okay. Oh, come on. Okay, so of course, welcome. We'll go through this orientation to online nursing courses first. You guys should have all received this handout, or the link to this handout in the modules and also in an inbox message. And if anyone didn't receive it, just reach out and I can get that to you. Okay, so what is online learning? Obviously, that means we're learning online through our computers and with the internet. So, you know, there can be issues sometimes with that. Just be in communication with me if you're having troubles with your internet, something like that. Obviously, you'll need internet access to be able to complete these courses. So do your very best to figure that all out. But if, you know, something goes on and there's a storm or something and you don't have internet access, just communicate with me if there's any concerns, okay? And then, this is a synchronous class every Friday from 3 Eastern to 5:30 Eastern. I'm in Central Time, so if I slip up ever and somebody has a question on, okay, is that Central Time, Brooke? Then just let me know. There's also interactive activities, the discussion posts. There's also the quizzes and the exams. We will do the quizzes at the beginning of our course, of our scheduled synchronous session when those are scheduled. Make sure you're, checking into your course. Okay, who do you contact? So first, you need to start with me. I'm pretty easy to get a hold of. I know a few of you guys have already been in touch with me. I think first, easiest way, I have Canvas on my phone. And if you guys inbox message me through Canvas, I get it pretty quick. I mean, I always have my phone. Who doesn't these days? So that would be the first step. The other step is in the course in the getting started section, and then the about the instructor section. It puts the steps right there on the slide for you. My contact information is in that about the instructor section, and also in the initial announcement has my cell phone number in there. I prefer that, that kind of be a last resort or an emergency thing, but absolutely, that's what it's there for. So if you need me, you can text me. That's the best way, is to text me. And then I will do my best to answer your questions. The other thing is the course lead instructor, that is Professor Bogart. So if you have any questions that I cannot answer, she is my mentor, so I will reach out to her. So if it takes me a minute to respond back, I'm probably checking in with her. But, if you have another concern, you can reach out to her, or also Dr. Brown, and her contact information is right there. If you would like to put that in your phones, or like do a little note of that. And then I can give you guys my phone number again. It is 515-333-1939. And like I said, please try to keep that as kind of last resort, but it's there if you need it. Okay, so first, like we already kind of talked through this, me, I'm available through the emailing, Canvas messaging, and then, if you need to get a hold of me in an emergency, by phone.
Really quick, can you repeat the last 4 of your phone number?
Yes, I sure can. It's 1939. So it's 515-333-1939. And like I said, that's also in that announcement as well. And if it's not there for some reason, let me know and I'll put it back up there. Once again, this is a classroom setting, so, try to be professional. I don't care if, you guys need to eat during this time. I understand, we all have chaotic lives, or if you need a drink or something like that. If you want to be in comfy sweatpants, pajamas, I don't really care, as long as areas are covered up. Okay. So once again, be respectful. We all have our own thoughts and beliefs, so we all have the right to have those thoughts and beliefs. So please be respectful. So attendance. So this is your attendance, right? Along with the discussion posts and any other assignments. So these are mandatory sessions. If you guys are 1 minute late, that is automatically a 15-minute late deduction. So just be aware. If your computer cuts out in the middle, hop right back on Zoom, making sure you have your chargers and all of that sort of thing. So that way, your computer hopefully doesn't die, and things like that. And then all the due dates, your syllabus is like your Bible essentially for this course. All the due dates are written out in the syllabus, and it's all according to that. It's all within the course. And if for some reason something looks odd or you're not being able to find something, just reach out to me and I'll do my best to walk you through it. Okay. All of the discussion initial posts on the discussion board are due by midnight on Wednesdays. And then you have to have 2 peer responses by midnight on Sundays. If you do your initial post and there's 2 other people that messages or posts there that you can comment on, and you want to do it all on, I don't know, Monday, I don't have any problem with that. Just making sure you're checking in to Canvas 2 different times within the week. Okay, so late work. So your case studies are open a week before they're due, and then they continue a week after. So that gives you an extra week on things. You have an extra week on things if you would need such, but you automatically get a 10% reduction. And if it's 8 days late, then it's an automatic 0. And I would like to know, okay, before it's due, this happened and, I haven't been able to get to it. So you guys can't let me know after the fact. I can't help you as much. So just make sure you're communicating with me. That's the biggest thing. Okay. Okay. And this is kind of talking about that whole, if you're 1 minute late, it's 15 minutes. So it's all recorded on Zoom, and it gives me the breakdown even by minutes of how long you guys are on here. And then I take attendance right at the end of the class. So make sure your guys' first and last names are in the, listed, and then that you're in the camera view the whole time, not aiming your camera up to the ceiling. And then you guys cannot be at work. You cannot be driving. That's obviously not safe. I will not be doing those things. So I expect that you guys not do those as well. And then if I see that, our camera is off or something like that, I will ask for you guys. I will call out your name. And if you still are not answering, then you'll have to be removed from the session. So, and then, like I said, attendance, that's recorded in 15-minute increments. And then anyone who isn't recorded in the attendance for 14 days in a row will be dropped from the course. So you don't want to have that happen to you. There also is no makeup for missed courses, like for missed attendance. So make sure you're coming in. So it's taken, we've already kind of talked about this, so I'm going to skip that one. And not only am I looking at the attendance, it's also, Professor Bogart and Dr. Brown, who are kind of keeping their eyes on that stuff as well. Okay, so you can, if you're absent more than 20% of the scheduled time, then automatically your letter grade is reduced, a full letter grade at the end of the term. So we'll give you multiple warnings before that happens, but just be aware that, if you're missing 20% of the course time, then you will have that automatic deduction. So keys to success. So review the work each week. I'm going to try to send out all the information and have it be out on by Saturday for the following week. I have a family myself, so sometimes things might get crazy, but if you don't see something, just reach out to me. Make sure you're opening your book, reading. That's going to be extremely important in all of your nursing careers. So learn. And one of the best ways to learn is to do your reading assignments each week. And then the interactive lesson, which is the discussion post or these live sessions as well. They're mandatory to help you guys kind of nail down and understand those concepts that you're reading about. And then also look at the rubrics for the assignments. If you have questions about the rubrics, you let me know. Make sure you're reading through all the directions of the assignments. Also complete all of your assignments. So the papers, the case studies, the NCLEX question, the discussion boards, those are all very important things. I know sometimes it may feel a little bit overwhelming or like busy work between all of your courses that you're in, but they are really important for being the kind of a foundation for your learning. And then study and then complete exams and quizzes as they're scheduled, of course. If an exam or a quiz or something like that isn't going to work out for you guys, let me know. I mean, obviously extenuating circumstances, not like, oh, I have to work unless it's an emergent kind of thing. Okay. So biggest thing is, like I've said 15 times already, keep in contact with me. I'm not a scary person. I do work a full-time job Monday through Thursday, so I may not reply right that second, but I will do my very best to get back to you, you know, within a 12-hour period, I would say for sure. Also, make sure you have, like I already said, a reliable internet connection, a computer or a laptop. This is very difficult to do from a phone. Maintain your schedule, like making sure you're completing all of your work, and then, you know, work in a quiet area that you're not so distracted, and then read the steps of the assignments carefully. So it's best to log in. I mean, like I said, at minimum, log in 2 times a week, but preferably log in 4 to 5 times a week to make sure, you know, you're not missing anything. You're not missing any announcements. You're not missing, you know, a comment on your discussion post that you could reply back to a fellow student, anything like that. And then I'm not going to put out a bunch of course announcements each week. How I plan on putting out the information is in that inbox, just like I did an inbox message, an email message with the links to that week's material, the PowerPoint, and then any other handouts or interesting things that I thought might be helpful. And then obviously don't procrastinate. So we're already in what, day 6. So you guys should have all been logged into Canvas by now. You guys should have all done your discussion posts, which it sounds like you guys all have and haven't had any issues. You know, print the syllabus. I would suggest printing that, or at least saving it to your computer so you have it. Like I said, that's your Bible. It has all your due dates, all of kind of the foundation information that you're going to be learning, the objectives, all of that. So also, you guys need to be in your textbooks. You should have already done the getting started section. It's finding your ebook on there. If there's anything, you're having any issues at all, let me know. I'm here to, you know, support your guys' learning and help you guys thrive. So make sure you're prepared to discuss the concepts each week. And then I will do some review sessions. I'll probably wind up doing them prior. My office hours are the 2 hours prior to the course. So if you guys need anything outside of that, you just email me and I can do my best to find a time that works for both of us. Tutoring sessions, excuse me. You know, if you need help and you're not understanding something, once again, reach out. I will do my best to talk you through what you're having a hard time understanding. And then obviously technical support. I can try to be your technical support, but sometimes I need that myself. So just go ahead and reach out to technical support if you're having a hard time. So, like I said, this is kind of all repetitive. So attendance is taken, do the review sessions, they're not mandatory, but it's encouraged. I'll do those during my my office hours. That's my plan. So make sure that, you know, you guys are popping in there. We can do like a little game or something like that to try to review things, to get you guys another, you know, hearing that information again. Your quizzes, the information will be from the week prior. So it will be information you've already heard. And then we will do the quizzes at the beginning of each class. And most of you guys will have 15 minutes, but you know, if you have accommodations, we'll talk about that later. So if you're doing the discussion posts and things like that, then you should be getting your full points. And, you know, if you're doing these review sessions, you know, it's likely that you guys will do better on the test and quizzes. Okay, so grading, it's all broken down here. So 55% is the exams for the unit. So that's 55% of your grade is just in those 3 exams. Quizzing, the quizzes are about 5%. The specialty exam, that's 20%. The case studies, all of that is 5%. The dose calculation worksheet, that's 1%, but it is really important that you guys know how to calculate weight-based dosing. That's something, if you're going to be a pediatric nurse, you're going to have to know how to do that, to be double checking your provider's orders. The NCLEX questions, those are 5%. The RN assignment exam, the HESIs, those are 1%. Your pediatric assessment, that is, you guys will, it's kind of 3 parts. So be looking into that to, you know, plan ahead, don't procrastinate. You guys will pick kind of a topic on pediatrics. You can pick whatever illness you want or something that interests you. You could talk about doing G-tube feeds. You could talk about NG feeds, anything you want. And, you know, if you're having a hard time coming up with something, you can reach out to me and I'll try to help you. But it's best if you guys do something that you're interested in. You guys will enjoy it much more thoroughly. And you'll write a paper in that section too, and do like an educational, like a teaching type thing that you would do with your patient or their family. And then the discussion questions, those are essentially pass fail. And then the Zoom attendance, that's a pass fail as well. Okay. So the grades, you guys won't see your grades until week 6. So from week 1 to week 5, the homework scores are kind of turned off. And then week 6, we'll turn them on. So you can see how, you know, maybe missing homework or things like that are going to affect your grade. And then we'll shut them off again in week 8. And then homework scores, those will stay off until after like week 12. Okay. So the combined score on all of your quizzes, exams, specialty exams, all of that needs to be 78 or above. Otherwise, we don't even give you any credit, unfortunately, for your homework. So if you do not have that C+, that 78%, then you will not get any credit for your homework. But if you do, then that's when you'll see that homework grade added in. And, you know, as long as you've done that, that should help bump you up. Quizzes, like I said, we'll do those at the beginning of class. They're going to be on the information from the week prior. You guys only get 1 shot. You cannot go back on your quizzes. So answer the first question, second question, you kind of go all through, okay? They're timed. There's 10 questions and then 15 minutes. And like I said, if you have accommodations, then that's different. And then when your quiz is done, make sure you turn it in. Exams, those are through ExamSoft. We don't put the exams in there until the Sunday before. So if you go into ExamSoft, you won't see anything right now. So don't get worried about you're not seeing any of the exams. That's on purpose to keep the integrity of the exam. And then, like I said, same with quizzes and exams. You only get one chance. You can't stop, you can't pause it, you can't resume. But if for some reason your computer goes black during the middle of a quiz or exam, especially during the exams, then let me know and we can try to figure out with IT and with Professor Bogart. She can help me find exactly kind of what happened and at what spot you were at. So hopefully, you know, we can get you back in there and be able to finish your quiz or your exam. And then of course the exams are timed as well as the quizzes. So make sure you're keeping track of your time. So I've kind of mentioned about accommodations. So if you have accommodations, I should have already received them, but if you have not sent them to me, make sure you send them to me, you know, by Sunday preferably, so I can send them to Dr. Brown, and I can also work on getting those accommodations set up for you. So if you let me know 10 days before and less than 10 days before exam, then I cannot grant you extra time, okay? And then exams, just like the quizzes, will be held during scheduled class time. And then obviously if you don't take the exam during the scheduled time, that will result in an absence, okay? And then exams can only be proctored on campus as long as you let me know 3 days in advance, because I have to be able to get that proctor the access code. So if you're somebody who wants to do the exam with a proctor on campus, then let me know 3 days before at least, okay? Preferably further in advance, but at least 3 days. So exams, just like our course, it's through Zoom. Unless you're proctoring with somebody in campus, you have to have your camera on, just like you do in our course time. You also need your driver's license or some sort of photo ID that has your first and last name on it and a picture of you. So I can compare that. I also will have you guys do a complete 360 view of your room, to walls, all of that. No, you know, I have my Apple Watch on, no Apple Watches when that's occurring. No earbuds, nothing like that, okay? Obviously, unless there's some cultural or religious reason for you guys to have things around your ears or clothing on, then, you know, that's a different story. But otherwise, you know, everything will be checked. So missed exams, those will be held to the late work policy. So exams missed without letting me know prior that you're going to be missing it, that will automatically be a 0, okay? And then exams for personal reasons that have been missed, that will, you know, result in the late penalty. And then that is if you let me know before. In an emergency, you know, that will require documentation on kind of proving what the emergency is, and that has to go to Dr. Brown. And I would also, you know, like that as well, but Dr. Brown is the most important one that you get. And it has to, you know, Dr. Brown has to be notified within 24 hours of the scheduled exam, okay? So, you know, if you get hospitalized or something like that, then, you know, you should be reaching out to Dr. Brown and myself to let us know, hey, I'm in the hospital, or my mom's in the hospital, or, you know, those extenuating emergency things that come up, okay? And then if it's not rescheduled to be completed within 7 days of the class that the exam was supposed to be done in, then that's an automatic 0, okay? So if you have anything that you feel like it might prevent you from being successful on an exam, get a hold of me before the exam, okay? I can try my best to work with you. I'm fairly flexible. If you get a hold of me afterwards, there's not much that I can do for you, okay? So I want you to succeed in this course. I want you to learn as much about pediatrics as you possibly can. And I want you guys to, hopefully have a little bit of love for pediatrics after this course. But, in order for that to be successful, you guys have to communicate with me and keep me, in the know. So once again, contact me. That's the biggest theme of this PowerPoint. Get a hold of me if you, have any questions or concerns. There's no dumb questions, okay? So just get a hold of me. Okay, homework assignments. So once again, look at your syllabus. Your syllabus is going to guide you on exactly what you need to do for your reading. It's going to, let you know what homework you've got done or need to do each week. And the other place you can look for that is the modules. Your modules will have all of what's due each week as well. Obviously, completing the reading is going to be a big part of it. And that would be best for you guys to do that before you do your discussion post. Okay. Because if you're trying to do a discussion on something you haven't read about, it might be a little bit difficult. And then it might also be easier for you guys to kind of keep things on track if you have a planner or a calendar and just write it all out when stuff due for each of your courses. That might be the easiest way. And then, make sure you block off time to be able to complete those tasks. Because if you guys aren't blocking off time for yourselves to do those things, it's very easy to think something's going to be a quick little thing and things can come up. Okay. Obviously, then the third step is completing the work, turning it in, and then submitting the work. So submit the work based off the rubric, based off the assignment instructions. So, you can go through and do this exact thing. So late work policy, late work will not be accepted without prior approval from the instructor. So once again, if you don't get a hold of me ahead of time, then I cannot accept your work, okay? If the instructor improves the submission of a late assignment, there will be points deducted. So even if I say, okay, yep, that's fine, there's going to be points deducted, okay? So once again, if it's done within that 7-day range, it's a 10%. If it's on 8 days or more, it's 0 automatically, okay? And there's nothing I can do about it. So really just communicate with me, okay? The NCLEX questions. So the purpose of the practice questions are for you guys to get prepared with the NCLEX exam, okay? That is the exam that is the gateway to you guys getting your RNs, okay? So the practice exams, doing those in each nursing course, that's kind of a stepping stone to getting you guys familiar with the NCLEX, okay? So those, just follow the instructions. If you have any issues with following the instructions, let me know. It's week 3 is when the review questions are in there, okay? So I'll just kind of click through this. I do not want you guys to do screenshots. So, save this as a PDF, all of that. So this has all the steps. You guys can refer back to this PowerPoint for those steps, or if you need help, just let me know. Okay, so grading, once they're graded, it will be what it will be, okay? You can repeat the questions as many times as you like to get the highest score. But once it's submitted, that's the score, okay? So you guys can do it 500 times if you wanted to get the best score, but once you click submit, then that's your score, okay? So I don't control the grading because that's on your guys' hands for how many times you guys want to do it, okay? So use the course text, the sections, the modules, use all of that to pull your questions from, okay? The screenshots are not acceptable, okay? So complete the documentation, okay? So 1 point per question. It has to have 50 questions. And then, 40 out of 50, that will be 80%, okay? And there's no bonus points if you get, all of them right. HESI, so HESI case studies and practice exam. So this will, also kind of be a guide for us as instructors to see how, we are doing with educating you guys. So the instructions, it should be in there already for you to see. It will open up, as the weeks kind of go by, but week 3 is our first HESI case study that's due. It's your first attempt. So if you go in there and do it, that's it. If for some reason it's showing in the grade book at some point as 0, let me know. And I sometimes there's an issue with the Evolve site that it causes there to be a 0 in there. So we will do our best to try and get that figured out. So the case studies and practice exams, those are you have to go through the Canvas course module and not just through Evolve, because otherwise it doesn't work correctly. So, and then those can also, like I said, they can be done through your Evolve account, but those will not be accepted unless you have some reason why you need to do it that way, okay? So grades will pop in there. This is kind of what I said. If there's a 0, because the grades pop in there automatically, let me know. I'll try to watch for that as well, but just let me know. And then only complete the case study for the link that's accessed, okay? Don't be trying to do all your case studies at the same time, okay? And then if you guys are repeating this course for some reason, we will have to reset your previous case study work because it saves it in there. So when I'm saying you cannot go back in, it's a one time and done, it is, okay? But obviously if you repeated this course, we'll have to go back in there and kind of reset it. So the discussion posts, we've kind of already talked about this in the writing papers. Find your instructions on this page that will explain all the steps to get to what you need to, and then follow your rubric, okay? This also is like your Bible. If you do all of these things in the excellent category, you'll get all the points. So just always read that, but especially, as you're working through it, it's helpful to have your rubric there and be double checking that you're hitting all of the marks. Use APA format. Purdue OWL is a great tool. It's just Purdue OWL online, I think is what it's called. You can just Google Purdue OWL and it will allow you to pull up APA, the 7th edition. They have a bunch of great references. It talks about how to cite, if you listen to a podcast, even it talks about all of that on there. So it's really helpful, but make sure you're using for your references, the nursing journals, or, our books, not podcasts, not YouTube videos, things like that. Okay. And then all of your references ideally should be no more than 5 years old. So let's see, 2018. or newer, okay? And then make sure your paper, your source relates to your topic. I will be checking that sometimes just to, make sure that there's accountability with that. And then make sure we're not plagiarizing. If you're going to directly quote somebody, put it in quotes. If you're using your own words to describe what you read, then you still need to cite it. Okay. So this is going to go through, how to access the quizzes. If, once again, we kind of have already gone over this, but if you're having issues while you're doing a quiz or exam, don't try and just fumble through it. So stop and get a hold of somebody, get a hold of me first. You can raise your hand. If your computer paused or something, or your quiz froze and you can't advance, get a hold of me. And then I will try to, look through and see what happened. Okay. And see when you stopped viewing, and see if we can get you back to exactly where you are with the amount of time that you need to complete the quiz. Okay. Or the exam. So I cannot allow you guys to retake the exam or the quizzes for technical problems or any other physical or emotional issues when the majority of the questions have been answered, or your time runs out. So if you've gone through 90% of the quiz, then it makes it more difficult. But if that happens, still let me know, and we'll do our best to see what we can figure out for you. The specialty exams, those are given. So the HESIs, those are given in the campus environment. They used to be on ProctorU as well, but it sounds like we're not necessarily going to do that like we did previously. There's only one attempt in pediatrics, so we only have one attempt. Okay, you'll have an assigned date and time for the exam, and then this is 20% of your testing grade. Okay, so the goal is for you guys to get a 900. Okay, so remediation is mandatory for you guys to get your actual score. Okay, if you do not do the remediation, then you guys will not achieve your scores. Okay, so there's the kind of, based on your HESI score, how many hours of remediation we have. Okay, and remediation packets are to be submitted by 1 a.m. Tuesday of week 12. Okay, and if you do not get that all completed, then it's a 0, and that's 20% of your grade, and you guys don't want that. Once again, you guys need to show your school badge for the exam. You'll need to have your camera on if you're, anytime you're doing an exam. If you're doing your HESI, like I said, those will probably be in person. So you won't have to worry about the camera in that situation. But your full face, I have to see that at all times. The proctor on campus needs to see that as well. And then if you do not have your photo ID or your face visible at any point, then that's an exam failure and potentially course failure. So review for HESI review, Dr. Bogart did a really good HESI review. I'm going to potentially do a HESI review as well. But she did a really, really good job. She has a YouTube channel, and I'm going to do all of my class sessions. I'm going to post them to my YouTube channel as well. So you guys will have reference to go ahead, and you can listen to this lecture 500 times if you want before exams and quizzes. And then, so remediation, you could, remediate with me, and kind of, I can walk you through, how that should look and all of that. Use your remediation, review your questions from homework assignments, maybe things that you had a hard time understanding, or, maybe sections that you found more challenging. How can the nurse maintain professionalism, if it's not in a hospital base? So all of those kinds of things, just to be thinking about those as you're going to sit for an exam. Okay. Okay. So that's the end of that one. Do you guys have any questions at all? No, hopefully you guys are all still awake. Okay, well, let me get this next PowerPoint going. We'll start our course content, okay? I'm gonna share my screen again here. Let me know if you guys cannot see it. Hang on a second.
Question.
Yeah.
If we need to like get up and go to the bathroom, or do we just
That's
like
fine. Yes, that's fine. I meant to say that in my announcement. Obviously, you can just leave your camera on and step out and then come right back, okay? Yep, that's totally fine. Obviously, just don't be in the bathroom, for like 10 minutes. Okay. Let me share my screen here. Okay. Sorry, you guys are seeing all my things there. Okay, so we're going to start with chapter 26. So pediatric 21st century pediatric nursing. So healthy people, you guys have probably all heard of healthy people. There is a goal, it's a national program that has multiple goals, pediatric, geriatrics, kind of every age group. There's different achievements that the nation hopes to accomplish by, so the latest healthy people is by 2030. Okay. So it goes in 10-year increments. So supporting family, the development of the family, mental health is a big, huge component this time and last time as well of the healthy people 2020 or 2030, excuse me. Nutrition, that's a key foundation. If kids are not getting appropriate nutrition, they're not going to grow appropriately and develop appropriately. And obviously they're going to have adverse health outcomes. Okay. So healthy weights, there's a lot of obesity. That's a huge focus of the 2030 healthy people section. And physical activity, there's been a drop in physical activity, which that, can lead to, sedentary lifestyles, and with sedentary lifestyles that, brings about more health problems potentially as well. Oral health, a lot of people don't have dental insurance. A lot of people don't have, even access to a dentist that accepts their insurance. So oral health is a big focus as well. Healthy sexual development and activity, talking about safe sex and things like that. That's a huge focus. Safety and injury prevention, also a huge focus with kids, safety and injuries. Injuries are frequent, unfortunately, in kids. So as safe, as many prevention strategies as you can to keep kids safe is the goal. And then, establishing community relationships and resources for communities, especially, impoverished areas or, lower socioeconomic statuses, and making sure that there's access to care in all of those places. Also, Bright Futures is listed on here. That is a good program through AAP and through Bright Futures. They have their own goals, but they always align with the Healthy People Acts. Okay. So child health problems, there's a lot of them. The main ones currently are obesity, type 2 diabetes. There's a lot of elderly people who have type 2 diabetes, but now with our diets and nutrition that we eat in America, obesity in childhood is a big problem. And, these kids are getting, adult considered diseases early in life because of nutrition. Okay. Childhood injuries, car accidents, drownings, things like that, accidental things happen. Child abuse, of course, falls under that as well as a non-accidental. Violence, obviously there's a lot of violence that kids experience. This is more typical, kind of in the adolescent stage, but obviously can happen at any age in childhood. Vaping, teenagers are vaping. It might be a big surprise to some of you guys to hear that, but it's happening, and it's really problematic. I've had kids in the clinic, even as young as 11, 12, vaping, and their parents had no idea. There's lots of variations to the vaping equipment that kids use, and there's variations to what kids are vaping as well. So just helping parents to kind of be aware of that. And then, of course, mental health problems. I would say probably 3/4 of the kids that I see, even for just well child checkups, they're having anxiety, they're having, kind of depressed mood, they're struggling. Social media is a huge stressor for kids these days, along with school, and, they may be being bullied, they can't get away from it because of social media. Okay. So here's kind of those pictures. So obviously access to a weapon, that's a problem. Violence, drowning for toddlers and infants, that's a risk. This girlie here is grabbing the hot pan, burns, getting access to medications that, you don't think a kid can get access to a pill bottle. They can prove that very quickly, that they can get access to things that you can't access. And then, of course, grocery sacks or plastic bags for asphyxiation, little kids putting the bags over their heads. So those are kind of all unintentional injuries that are typically most common in kids. So highest risk kids for all, childhood health problems, premature kiddos. So those babies that were in NICU 35 weeks and less, very risky for health problems. Okay. That's just an automatic increased risk factor. Very low birth weight or just low birth weight. So VLBW means very low birth weight, and LBW means low birth weight. So that kind of goes along with prematurity, but you can have very low birth weight and low birth weight infants that are not premature. So that's an automatic risk factor for, kind of predisposed things for obesity or all of those other risk factors. Okay. Kids that go to daycare. Okay. What happens with kids that go to daycare? They're snotting all over each other, sharing their germs, right? So they're going to be more at risk for respiratory illnesses or, vomiting, diarrhea things, hand, foot, and mouth, all those glorious things that kids that go to daycare experience. Same with at school, as they get into school, they're exposed to all sorts of things. Impoverished children or homeless children. There are children you may not even know that, are homeless and live in their car or, don't have access to much of anything, food, anything. So obviously, if you're living kind of in that fight or flight mode all the time, you're going to be at risk for more health problems than a kiddo that, has a home and has access to more things. Immigrant families, sometimes those are the sickest kids that we see. A lot of times immigrants are scared of being, sent back to their home country. So they don't necessarily bring their kids in until they're really, really sick. And of course, when kids present, we treat them, whether they're immigrants or not, we treat them, we take care of the sick kids, but that's a risk factor just because they typically wait until their kiddo's pretty sick because they're fearful. Chronic medical conditions. So, cerebral palsy, asthma, those are chronic things. A lot of times, that's going to predispose them to potentially developing other issues. Psychiatric illness, mental health is a huge thing. And if we're struggling mentally, then a lot of times, kids may have physical struggles as well. And then, of course, disabilities kind of, if your child's a nonverbal child, they're at higher risk for child abuse or complications like that. And then barriers to adequate health. So, like I said, not having access to a healthcare provider because they can't get to their appointments because they don't have a vehicle or they don't have a reliable vehicle, or they don't have anywhere within 50 miles that accepts their dental insurance. So kids aren't seen by the dentist. That is a common problem that I have in my clinic with my patients. Our state insurance, some dentists just don't accept it because they don't pay as well. So access to care is a huge struggle in all categories. Psychiatric care, access to psychiatric care, not being able to access that when needed, that is a problem nationwide, pediatric wide, adult wide, for everyone. It's a big struggle, and it's a big risk factor if kids have psychiatric illness and they're not able to get care. So infant mortality. So that mortality is the number of deaths per 1,000 live births during the first year. So looking at that number. So in the United States, we have a fairly high infant mortality rate. So neonatal, that's looking at the first 28 days of life. So less than 28 days or less, okay? Or 27 days or less. Postnatal mortality, so that's considered 28 days to 11 months. So from postnatal is 28 days to 11 months, okay? Like I said, our infant mortality rate is fairly high, especially if they're low birth weight. So if they're less than 2,500 grams or 5.5 pounds, or if they are, born into a poverty situation, that can kind of play a factor as well. But the biggest determinant is birth weight, low birth weight, okay? Childhood mortality, so death rates in kids a year or older is typically less than infants, okay? So an infant is at higher risk of dying of RSV than a 4-year-old, because the 4-year-olds had 4 years that they've been exposed to RSV. An infant who is exposed to, herpes, they're at way higher risk for complications than kids that are 4 and 5 because their immune system hasn't fully developed yet. Kids about 5 age to 14 have roughly the lowest death rate. They're kind of in the safe category, right? They're not taking as many risks. Parents usually have a lot of eyes on this age group, or, other caregivers typically are supervising these kids a little bit closer, so they're able to make less dangerous choices. And then obviously there is a huge drastic increase on the charts for adolescent mortality. So the highest cause of adolescent death, is typically firearms, suicide, homicide, and then, injuries like motor vehicle accidents, things like that. Children, okay, so specific kids, so we go back to the high risk kids. So homelessness, that has an increased risk for illness, which is morbidity. Okay. Mortality is death, right? And morbidity is illness. So kids who are homeless, they have an increased risk for getting sick. Thus, if they have an increased risk for getting sick, then they probably also have an increased risk for mortality compared to a kiddo that maybe isn't homeless. Okay. Living in poverty, another risk for increased morbidity. Low birth weight, that's the number one indicator for infant mortality. It's also a risk factor for illness later in life. Chronic illnesses, so kids who have asthma, kids who have developmental disorders, so like different syndromes, Down syndrome, CP, cerebral palsy, things like that. Those kids are at more risk for illness. Okay. Foreign born adopted kids. So those kiddos are at higher risk because a lot of times they're coming to an environment that is different than their home country with different germs. And they a lot of times also are not vaccinated for all of the things that we vaccinate here in the United States for. So that puts them at increased risk for morbidity or illness as well. Children in daycare centers. So once again, kids in daycares, they're sharing germs with each other. That's kind of what they like to do. So swap and spit and, all of that drooling all over each other. So that puts them, at higher risk for illness. So philosophy of care. So in pediatric nursing, you're going to not only care for your patient, right? Like you do in the adult world, you're also going to be caring for the parents. Sometimes the parents can be difficult. Okay. But if you work with them to do the best to care for their kiddo and teach them things, a lot of times they're more appreciative and they're more receptive to the learning. So family-centered care. So a family is what the child says it is. Okay. So it doesn't have to be a mom and a dad. It doesn't have to be, a mom or it could be a mom and a grandparent. It could be grandparents. It could be aunts. It could be family friends. So, that is what the child feels that the family is. Okay. So it's important to educate those people that the kiddos feel are involved in their family. Okay. So systems, you have to support, respect, encourage, enhance, and strengthen the confidence of the family so they can help the child, because you won't always be there with them. So you need to teach them, give them the tools to care for their kiddo when they're, going home from the clinic or ER or hospital. Okay. So all the needs of all the family members must be addressed. So if you have a parent, a mom or a dad who is really struggling and to understand what you're trying to teach them, try to teach them in a different way. All of their needs need met. You have to think about parents, you're meeting them kind of in their worst time, potentially, especially if you're a nurse who's in the hospital setting. You're kind of seeing your patient and their parents at the worst time of their lives, potentially. So just meeting them where they are to work together to care for their child. Okay. So you also have to be able to empower your patients, your kids, and the parents. So, if they're struggling, give them tools to involve them in the care. Teach them how to check a temperature of their baby under the armpit or rectally. So that way they can do that for you. When their kiddos in the hospital, they can be a good set of eyes for you as a nurse who cannot always be in that room with that patient. So allow them to be involved in the care. Okay. Family. So like I said, family is whatever the individual considers it to be. Okay. And then it can be a variety of different individuals. They may all have the same values. They may have completely different values, but, to be non-judgmental and to, still consider all of the individual people in the room that the patient considers family. Okay. So the role of the pediatric nurse. So a big part of your role as a nurse in any setting is therapeutic, right? You have to have that therapeutic relationship. You have to be having open communication with your patients, and also in pediatrics, their family members. If you're going into a room and just doing all the things to the kiddo without explaining anything to the parent and the child in ways that they can understand, that might make your relationship a little turbulent. So, explaining what you're going to do in ways that people understand before you do that, that helps build that relationship. Okay. Being an advocate, obviously that is a huge part of nursing. You guys are the eyes and the ears for providers, and for the family as well when they're not around. So if a family member comes to you with a concern, especially if they've voiced the concern to a provider or someone else and felt unheard, it is important for you guys to, be at those advocates and show that you care about the patient and what the family's concern is. Okay. Sometimes you guys may come up against a little resistance with that, but it's important that you guys know that's something that you're supposed to do for your patients. Okay. Disease prevention. Obviously, we don't want, we work in a hospital, but we don't really want people to have to be there. So preventing the disease is kind of the first step in not getting people in the hospital. It's a difficult task at times, but that is a huge part of the pediatric nurse, educating parents, with the kiddos who have been in the hospital on, let's say they've had a kiddo in the hospital on oxygen because they had a respiratory virus like RSV, and, they have a lot of gunk in their nose. So educating the family on how to suction their nose out with saline, for when they go home, hopefully then next time they get a viral cold, then, the parents can remember, oh, hey, they taught me how to suction the nose out, before I feed them. And maybe that will help them not wind up in the hospital again. Okay. Promoting health. So, encouraging kids to get exercise, make smart choices with food, all of that kind of stuff. That's a part of the pediatric nursing role as well. Teaching, health teaching, that is probably going to be, along with the therapeutic relationship, that's your first step, but health teaching is probably 80 to 90% of what you will do as a nurse in any setting. Teaching your patient something, teaching their family member something, and then having them teach it back to you, to make sure that they understand, what you're talking with them about or teaching them, so their child can get the best care, when they're not in the healthcare setting. Okay. Talking about preventing injury. That's another huge one. Obviously, as we saw, a lot of childhood death is related to injury. Well, there's things like car seats. There's things like helmets. There's things like, gun safes. Talking also smoke detectors. People forget about smoke detectors sometimes, or carbon monoxide detectors. So all of those kind of teaching injury prevention items, you as a nurse will be responsible for helping parents be aware of that. You also have to use your clinical judgment and clinical reasoning. Now, this starts to develop while you're, in your first clinicals. You're working on this. You guys may feel like at sometimes you haven't learned anything, but each time you're working on developing your judgment and your reasoning. Okay. So there's 6 skills that you guys should do. So you should be able to recognize cues, analyze the cues, prioritize, kind of the options, and then pick the solution that's best, do that solution, and then see how it went. So, if you're trying to teach somebody something, you can see, okay, are they picking up on what I'm saying or not? Okay, if they're not seeming like they're understanding, ask them, okay, can you teach me what I taught you? things like that. And if they're not understanding, then try and work with them in a different way. Okay. And that helps you develop your reasoning and your judgment as well. So the art of pediatric nursing. So atraumatic care. We as pediatric nurses and providers do not want to, hold kids down, stab them with shots, and, stab them with needles to get their blood. If someone did that to your child or someone did that to you when you were a child, I don't think things would have worked out too well. And you probably would have been scared to death anytime you came to the doctor. So, focusing on, using numbing cream if they're going to be getting a shot or if they're going to be getting their blood drawn, doing distraction tools, having them play on a little tablet while you draw their blood, using different terms so that way kids, don't lose it when you say, okay, I'm going to take your blood. Well, kids are thinking that you're literally going to take their blood and they're never going to get any blood back. So, just picking your words and reducing, the potential of that psychological distress and also minimizing the physical distress. Obviously, kids do not like shots. Kids do not like blood draws. But if you put numbing cream on and then ask them to pinch their skin in that area and say, ooh, see, you won't feel anything, then that kind of helps. Child life is also something that is available at some hospitals, especially children's hospitals. They are people who can distract the kids. They do all kinds of fun stuff. They're child life specialists is what they're called. So a lot of times they do games. They help kind of distract them with toys or a tablet, things like that. So the other thing is not doing hurtful things in the child's patient room. So a lot of places now have treatment rooms or procedure rooms that you will take the child out of their room that they're in the hospital in, take them to the procedure room and do the harmful thing in that room. Because then kids realize, okay, bad stuff doesn't happen where I'm staying. It happens in this other room. So they won't like that room, but they will be able to easier and be less stressed when they go back to their room. And obviously you don't want to do harm on purpose. Okay. So family, social, cultural, religious influences on childhood health promotion. That's the chapter 27. Okay. Family structure and function. So family, the traditional nuclear family, that looks like mom, dad. Okay. Blended family, that can be, or mom, dad, mom, that sort of thing. A blended family would be one parent and like a step parent or a girlfriend or a boyfriend, vice versa. Okay. Extended family. So that's going to be grandparents, aunts, uncles, cousins, all of them. Single parent family, obviously that is one parent is involved in that picture. LGBTQ, those families that can be involved as well. Communal families, so like Amish groups and religious groups and all of that can be involved as well. Okay, there's very different ways to look at family, and like we said, family is who the individual perceives it to be. So strengths and functioning. So family functioning, you as the nurse can help strengthen and, meet your child's needs, and your patient mean families as well. Okay. So you can encourage them and by educating them. You can also be like a therapist for them. Sometimes they just need somebody to listen. And you can also help them identify their strengths and maybe some weaknesses, some things that maybe they'll struggle with, and you can work together on those maybe things that they're struggling with. Okay. So the nurse, you have to understand your patient's social, cultural, religious influences. If you do not know what that patient's social, cultural, or home life looks like, religious life looks like, it's very hard to, be able to tailor individual care to that child and that family. And it's very hard for you as the nurse and the family working with you to understand each other. So being aware of that is one of the first and easiest things that you guys can do is, ask, do you have any social, cultural, or religious views that you would like me to be aware of? Obviously, the surrounding environment. What does their school setting look like? What kind of peer group are they in? Are they making good choices with that peer group? Are they in a community that's, high violence or lower economic status, things like that? Those have influences on the child and the family. And then, of course, social media and the news media, those can also influence, the child and the family's relationship and their relationship potentially with you as a nurse. So race and ethnicity can influence the child and family relationship as well. Poverty, parental education, if parents are, they didn't graduate high school, that can definitely influence, how the child is going to learn and their perspectives of the world as well. If they're immigrants and they don't really understand our culture, that can affect the influences on their child in the school environment and all kinds of things. So just being aware of people's backgrounds is very helpful for you as healthcare providers, okay? So question. So what is a frequent health problem of migrant children and adolescents in the United States?
C.
Yeah. Anyone else got other ideas? Or C, right, do you think?
B.
B? Yeah, that can be. But for migrant children and adolescents, so these all can kind of be options, right? But
Is it A?
so a frequent health problem would be diabetes, right? So when you look at that question, yes, suicide can happen, right? That's fairly frequent. But diabetes is the most frequent out of all of those, okay? And it's a health problem. Suicide, you have to look at it as a health problem, but not necessarily a health problem. Does that make sense? Okay, cultural health beliefs. So like I said, you have to be aware of the culture that your patient is from. People live by different rules and different priorities. And, it's best to kind of be aware of all of those things right off the bat. Then that way you guys can start to establish your relationship, your therapeutic relationship. Okay. So what are the physical aspects of caring for the body, right? So some cultures have special foods, special clothes, special medicines that they want to, utilize. And none of that's going to be overly harmful to the patient. Okay. If they want to have their child wear certain clothes while they're in the hospital, that's not going to cause harm to the patient. And then, what are the mental parts of caring for the child? So you have to look at the feelings, attitudes, rituals, actions. Every culture has different feelings about something. Some parents or cultures look at, if their kiddo has a broken leg or is in the ER in a lot of pain, that kiddo needs to tough it out and not get any pain medicine, so that can kind of sometimes be something that you may encounter. Doesn't make it right necessarily, but that's how they feel about it. So, they may refuse pain medication for their kiddo. Another thing is spiritual aspects of care. So pastors, preachers, saying prayers, healers. Sometimes this can look different for, each culture. while they're in the hospital. And once again, these things likely will not affect the child's health outcomes, okay? So health beliefs. So looking at what caused the illness, right? So sometimes illnesses come from like forces of nature. So hurricanes, snowstorms, things like that. And this is looking at cultural. Sometimes, you know, in cultures, there's, when it rains, you know, they're looking at, if you go outside, you're going to get sick in the rain. The cold air makes me sick, things like that. You know, supernatural forces. So voodoo, witchcraft, evil spirits, you know, some cultures feel like they have to ward off evil spirits, things like that. And that can be helpful for their kiddo when they're in the hospital. Obviously, imbalances of forces. So a cold and hot imbalance. Sometimes culturally that is something that other cultures focus on as well, especially when their kiddos hospitalized, okay? They may all have different health practices. Some cultures, you know, they have somebody that they go to first before they can come to, you know, our healthcare setting, you know, to kind of get the okay to bring their kiddo to us to be seen, okay? So religious beliefs, there are, you know, some religions, you know, Jehovah's Witness is one that if their kids need blood, they're not necessarily, you know, they're not into that idea. So when kids really need blood and they're Jehovah's Witness kiddo, you know, sometimes we have to get the court involved or an ethical committee involved to be able to provide that child with blood. Obviously, when that's happening, the parents and family can be, you know, really uncomfortable about that. So, you know, to respect their beliefs and their values, you know, try to keep the blood covered up. Things like that can be just some little things that you can do to make the family more comfortable with it potentially. If you're doing something to their child that, you know, they're uncomfortable with, but it's necessary to have to be done, okay? You know, food, sometimes certain foods are like a cultural thing and, you know, maybe that kiddo has food sensitivities to that. And, you know, some of the family members don't necessarily believe that or understand what that looks like and how that can affect the child. So, you know, working with the family with their beliefs, but also, you know, trying to explain, okay, for this child, you know, they're allergic to gluten or something like that. And then, like I said, natural remedies, medicine. Some people, some cultures use herbal remedies or some other things like that to, you know, treat their illnesses as well as, you know, Western medicine. So just being aware of that. Most of those things, you know, obviously if a kiddo doesn't get blood and they need blood, that's pretty problematic. But, you know, most of those things culturally will not harm the child. So just being involved in that. A lot of times families like to explain, you know, why they believe what they believe. And it can also help build your guys' therapeutic relationship with your patients. Okay. So pediatric nurses, you also need to support and counsel your patients, right? Like I said, sometimes you are the only person that a parent may see all day when they're in the hospital, and you're the person that's there all the time. You're not the provider who just kind of comes in and out when needed. So, you know, you need to be able to answer their questions. They need to feel like they can talk with you about things. They need to feel like you'll listen and, you know, not give them advice and give them advice when they want advice. You know, you also need to help collaborate and coordinate their care. So, you know, if an infant's sleeping with their mama and, you know, you need to do their vitals, something like that, you know, you can do their vitals and also the provider can come in potentially at the same time and talk to the parent, you know, wait, less interruptions and coordinating that care so the family has some time to themselves as well. Okay. Obviously, you need to be ethical in your decision making, and use evidence-based, research-based practice care. Okay. So the leading cause of death in African American boys aged 15 to 19. What do you think that is?
Suicide.
I'm gonna go with C.
C? Yep, that's right. Firearm homicide is kind of, kids are higher risk for that. Suicide is also one in that age range. But with this question, it was looking more specifically at African American boys in that age range. Okay. Okay. So developmental and genetic influence on child health promotion. So chapter 28. So foundations of growth and development. This is referred to as the number of changes that take place during the lifetime of an individual. So growth, development, maturation, differentiation, and then interrelated. They can happen, they can be related. Like one thing has to happen for the other to happen, can all happen at the same time. They can skip steps in the developmental curve, and development is ongoing throughout the lifetime. So growth, that's an increased number and size of the cell as they divide, synthesize to new proteins, and they result in increased size and weight of a whole. So that's quantitative. Okay. So development is a gradual change or expansion that is advanced from lower to more advanced through stages of complexity. Okay. So that's more qualitative. So quantitative, that's kind of looking at the number. Okay. And qualitative is the change over time. Maturation, so that's an increase in competence, ability, usually described as qualitative change to function at a higher level. Okay. So you need kind of those qualitative things to happen for maturation to happen. So differentiation, that's looking at the process which early cells and structures are systematically modified and altered. So those things all have to happen, right? Things have to happen in order, or they have to happen all simultaneously for kids to grow and develop. If kids don't have good nutrition, then they're not going to be tall, or, they're not going to gain weight. Their brain's not going to develop fully. All those foundation building blocks for later in life. Okay. So stages of development. So we'll get into this more specifically as we go on in this lecture, but each stage of development has tasks that need to be accomplished for kids to move to the next stage. Okay. So like I said, some kids go in a directional pattern. They're going to check all the boxes in a row. And then some kids, jump around. So some kids may, crawl before they're walking along furniture. Some kids may walk along furniture before they're crawling. It doesn't have to be in the exact order every time. And then there might be variations with individuals, correct? So there might be a 3-month-old who can roll forward to backwards. There may be a 2-month-old who can do that, but the kids may also not do that until they're 5 months old. There's variation, okay? Sorry, I'm just looking at a chat. Yes, I do have the PowerPoints available. It should have came to you guys in a inbox message. So I'll send that back out in case you guys didn't get that. Did everyone get that? It should have said like week 1 information, I think.
I did not get that. I was actually going to ask you for the PowerPoint because I looked under modules and announcements and inbox and everything, and there was nothing. So
Okay. And that's Megan.
I'm Sarah talking.
Oh, Sarah. Okay. I can't see
Yeah.
you for some reason.
It's okay. Oh.
Okay. Yeah, I'll send it back out again, and then you guys just let me know if you haven't got it. Okay.
We just aren't really used to getting things in our emails like that. Like they're normally uploaded in modules or announcements. That's what we're used to looking for
Okay.
the for. That's why I was like, I can't find it, but it makes sense. I haven't really checked to see if it's in the tasks announcements or
In the inbox.
inbox. Yeah, I haven't checked that because we're not used to getting them that way. So it
Yeah.
was
Okay.
really forefront of the mind.
Yeah, that's okay. And I could have put that in an announcement initially that's how I'm going to do it. But okay, well, that's fine. And if you guys want a weekly announcement, I can sure do it that way. It just gets sticky with trying to put all the attachments in the announcement. It will only let you do one at a time. So that's why I think inbox through Canvas is the easiest way. Okay.
Yeah, that's whatever's easier for you too.
Okay. Okay. So if you guys can't find stuff, just reach out to me. That goes back to the communication stuff. Okay.
Right. I have a
Okay.
question about this
All
slide
right.
though.
Let's go on. Okay. So foundations of growth and development. So metabolism, right? So kids have to be able to metabolize the food that they're receiving to do the basic body functions to develop their brain and to grow. So they also need temperature controlled environments, especially when they're infants, right? That helps the thermal regulation, helps their brain to develop and grow, and the rest of their body to mature as it needs to and grow and develop. Sleep is one of the most important things, along with nutrition. Okay. So the nutrition alone is the single most important influence on growth. So like I said before, if kids are not getting the nutrition that they need, it's going to make them at increased risk for a lot of health problems down the road, right? And they may not, grow to their potential height if they're not getting the appropriate nutrition, or, there's a lot of factors that can come from nutrition and sleep as well. If they're not sleeping, they're not going to do well at school. They're not going to probably be as willing to work with you with behaviors and things like that. So that's a huge part of developing how they think, how they behave, how they react. The easy child, that's a kiddo that, is easy to work with, easy temperament, easy going. You can change up the routine for them, and, they don't throw huge fits. Difficult children, they have to have the exact routine. They have to know what's happening, or, everyone's going to pay for it potentially. Slow to warm up. Those are probably the hardest kids to work with, especially if you are a nursing provider. The easygoing child, you can go in there and say, hey, what's up? Let's go check your muscles, or, we have to check your muscles with the blood pressure cuff, things like that. If you say that to a slow to warm up kid or a difficult child, they're going to be like, nope, no way. And I'm not talking to you. So just kind of understanding the temperament of your patient and the child that you're working with and the family that you're working with as well. Okay. So there's different psychologists essentially and developmental people who have worked with human behavior over the course of the time. So Freud is one. He looks at psychosexual. So, and we'll go into these all in more detail. Erickson looks at psychosocial. Piaget looks at cognitive development. Kohlberg looks at moral development. And then Fowler, which that one is not used as frequently, looks at spiritual development and how that affects, human behavior. So theoretical foundations. So this is Freud. So psychosocial. So kids in the oral stage, birth to 1 year, they are, living off of a bottle or a breast. So very much oral stimulation. They cry, they want something in their mouth. They cry, they want their passy. They cry, they want a bottle. That is kind of the oral stage. The anal stage, those kids, 1 to 3, they're getting curious about their areas, right? They're working on potty training, controlling their urination and their stooling and figuring all of that out. The phallic stage, kids are getting even more curious about their private areas, learning, people shouldn't be touching those types of things. Okay. And latency period, that's 6 to 12 years, kind of that middle childhood where they're not necessarily focused on one section, but kind of still working through all of those previous sections. And then genital stage, of course, that's in adolescence, when they're more sexually active. Psychosocial development, so that's Erickson. We will go into Erickson in more depth next week, but there's also a handout that I'll send out again in that week 1 information that you guys can reference as well, that breaks Erickson's ranges down very well, easy to understand. So trust versus mistrust, that's birth to a year. Obviously, they're going to be either trustful if their needs are met, or they're going to have mistrust because their needs weren't met. So if a baby's not fed, or if the baby's diaper isn't changed, they're going to likely have mistrust as they go on. Autonomy versus shame and doubt. So that's kids age 1 to 3. So, they want to do things by themselves in their way. Or if they aren't allowed to do that, then they may, have shame and doubt themselves. Okay. So initiative versus guilt, that's ages 3 to 6. So they are going to take the reins and they're going to make that choice. And if they're not allowed to do that, they're going to feel guilty. Or the other thing is they may make a choice and maybe it's not the right choice, and then they'll feel guilty about it. Okay. Industry versus inferiority. So that's looking at, the group versus me. And then identity versus role confusion. So that's me trying to identify myself as an adolescent versus others trying to identify themselves and kind of getting confused in that role. Like, where do I fit kind of thing. So Piaget, cognitive development, there's also a handout on this as well. Sensory motor. So those kids are sensory kids. So they're learning how to eat. They're learning how to interact with the things around them. Pre-operational, those kids are interacting with their environment, but they don't necessarily understand the environment fully around them. Concrete operational, those kids have a fairly good understanding of things that are happening around them, but it's just kind of the basic level of the understanding. Formal operations, these kids are making choices themselves. They understand the choices. They may not understand all the consequences, but they understand more consequences than the 7 to 11-year-olds that don't necessarily understand the consequences and all the options. Language development. So born with a mechanism or capacity to develop skills in language. So kids should be talking at least a few words by 18 months. If they're not talking at all, that's concerning. Okay. So their environmental means. So if kids are in an environment where there's no communication going on, they're going to struggle with developing their social skills and their language skills, right? They may also struggle with physiological structure and function around them. That if they struggle with that, it's going to be hard for them to kind of move on to those next steps of cognitive development. Intelligence level, that's something you have to look at. If kids are developmentally delayed, they may kind of go through those phases a little bit slower at a different pace than their peers. They also have to have a need to communicate. I don't know if any of you guys have seen the 2 and 3-year-olds that don't want to talk. And when they don't want to talk, they're not going to talk. Or I have some little boys or little girls too that have older siblings. Well, those kids, the younger kids, don't need to talk because the older siblings just go and do whatever they're motioning for. So there has to be that need and that necessity to communicate their needs for language development to occur. And then they have to be stimulated. If the kiddo is not stimulated, is in an environment where they're just kind of laying around all the time and not communicating, then there's going to be, and not being around people communicating, then there's going to be a lack of stimulation, and they're going to have a hard time with language development. Moral development, so that's Kohlberg. So these are pre-conventional level and conventional level, and then post-conventional. So pre-conventional is, those infants, right? They're not exactly, they don't know good and bad. They just think everything's good. Conventional, that's when they're starting to learn, good versus bad. Kind of more those preschool kids, the young school age kids. Post-conventional, they're working on autonomy. They understand good and bad, that there's good and evil in the world. And they're starting to understand and figure out those consequences. So the role of play in development, obviously play is a huge part of figuring out the world for kids. That's how they interact with the world and learn. So content of play, so social affective play. So they are playing, they are learning how to interact with things and the environment around them. Socially, they're interacting with parents. Parents are reading books, interacting, playing that way. A sense or pleasure play. So kids like to feel things, touch things, smell things, get that sensory stuff going. Kids really enjoy that, and they learn a lot from that sort of play environment. Skill play, so that's kind of them demonstrating skills, doing skills, watching you guys, observing parents do skills, and then, mimicking, you guys as nurses listening to the heart. Well, they want to listen to the heart like you did, things like that. Unoccupied behavior. So that is, they're playing by themselves and not being watched. Dramatic or pretend play. That is a huge part of development. That typically comes around, 2 to 3 years. Kids will start doing that. Sometimes around 18 months, they'll start playing doctor and nurse and all of that kind of stuff. And then games, obviously that's a part of development too, learning the rules of games, how to interact with the games and the other players at the table. So toys, so sensory motor development. Toys are a huge part. So like kinetic sand, that's something good, sensory motor toy development. Intellectual development, toys also help with that. Kids are learning how to figure out the toy. They're getting all the things all over them, like this kid in the picture, the paint all over. It's going to be a mess, but that's how kids learn and interact with their environment. Socialization, if they're playing with toys with other kids, they may not even be playing together, but they're still socializing their benefit from that play. That's called parallel play. Creativity, to let kids play with toys and make up their own story and develop their own story. That's a beneficial way to self-awareness, being aware of where they are at in play and, are they playing with other people or are they kind of by themselves? Onlooker play, so that's I'm watching somebody play. I'm not playing, I'm watching someone play. Like, so parents a lot of times are doing onlooker play. They're observing their child. Solitary play, so that kiddo's just playing by themselves in their own little world. Parallel play, we're playing the same thing, but not together. Associative play, we're playing at the same time, but not paying attention to each other, but playing different things. Cooperative play is we're playing all together. And those, kids work through those stages of development as they develop as well. Toys, kids learn from toys. They learn how to do fine motor skills, gross motor skills, all of that sort of thing from toys. Screening procedures. So developmental assessment, these are things that we look at as nursing providers and or nurses and as providers. Our kids, meeting all of their development milestones? Are they progressing through, like they should be? Or if there's concerning things, getting those kids into intervention, things like that. Looking at their age and the stage that they're at, does that align? Looking at kids with developmental disabilities or other physical disabilities. And then, getting kids that are behind into early interventions. Congenital anomalies. There are a lot of different anomalies that can happen. So like clubfoot, cleft palate, things like that. There can be malformations, there can be dysplasia, there can be, abnormalities in sweat glands, things like that. So the other thing that can affect congenital abnormalities or like syndromes to come about is the environment in the uterus as they're developing. So genetic syndromes, obviously everyone or most people have heard of Down syndrome, but there's so many genetic syndromes. Some of them are just named by the genes that are affected. And then obviously there are some drugs that can play into if moms take these medications while they're pregnant, that, may put baby at increased risk down the road. Sorry, it's kind of hard to see this one. So genes, so genetics, obviously that plays a factor in influencing development. If kids are having, genetic abnormalities, then it's likely that, they'll be affected by that potentially. And it's also important for you as a nurse to understand, okay, this kiddo has Down syndrome, I need to do this versus this, because, this might go over better for me. Okay, so development can be affected by, chemicals, infections, physical things, metabolic things. All of those things can affect growth and development of kids. So if there's exposure to alcohol or, drugs while they're developing in utero, then it's likely that they will be affected, throughout their life from that. They may have intellectual disabilities or other things kind of happen. And obviously genetic disorders, a normal gene, there's an X and a Y chromosome and then 22 pairs of chromosomes, okay? And that's in a normal situation. Obviously there's syndromes, there's variation of that, okay? So you guys need to be aware of genetic things to be able to realize when your nursing assessment may be affected, okay? So, and to be able to continue to assess the child's ability to cope with what's going on with them and know where the child's at developmentally to be able to interact with them appropriately. Okay. Okay, so a child tells a nurse that the child, or a father tells a nurse that the child is filling up the house with collections like seashells, bottle caps, things like that. So the child should recognize that the child, or the nurse should recognize that the child is developing what? Does anyone know this? Okay, so object permanence, that's you put something down for typically an infant and cover it up and they think it disappears, right? So that's not this. Pre-operational thinking. So that's like looking at, okay, I may need this for something. I may really want to remember this. So I'm going to keep everything. So that's what it is. Oh no, excuse me. See, During concrete operations, they're trying to figure out, sort through what they may or may not need. Okay. Sorry, I misspoke. So they're using things that they find in their environment to interact with the world. Okay. So that's why they're creating connections. So that is concrete operational thinking. Okay, chapter 29. We're doing okay on time, I think. So, okay, so let's quick through. Okay, so HIPAA, obviously do not communicate with anyone who you cannot communicate with. Look at, in pediatrics, the big thing is there are certain things that as kids get older, you cannot talk to their family about without getting the okay from the parent or from the child, okay? Especially if they're 18, and a parent is wanting to know information. If the child does not want the parent to be aware of what's going on, then, you cannot tell them that. And HIPAA is something that will get you in big trouble if you break it. So just be aware. So communicating with parents, encourage the parents to talk. You need to be empathetic to parents, even if, they're not necessarily understanding what is going on. And then the other thing is if you have a patient that needs an interpreter, do not use a family member, always use an interpreter, okay? You don't know exactly how that family member is interpreting the question. So always use an interpreter, okay? So there's a variety of different techniques to use for communication. Obviously, open-ended questions are the best thing, okay? Leaving the conversation open, that will allow for questions and further understanding, okay? And then obviously playing with children is a huge way that you'll interact with them and communicate with them. And you also have to take in effect the developmental spot that the child is at. So while you're doing a health history, you're going to look at, okay, why is my patient here? What is their chief complaint? What did they come here for? And, when did this all start? And, what do their symptoms look like? When did it start? Things like that. That's kind of the first step. Figure out why they're here. History. So birth history that is involved, any previous illnesses, surgeries, allergies, meds. We want to know what their immunization status is. Have they had their vaccines? Have they not? Are they behind on vaccines? Where are they at? Have they met their milestones appropriately? What are some habits or things that the kids like? Because, if there's particular things that kids like, you as a nurse, that's beneficial for you to be aware of. It might make things easier for you while you're caring for them. So you should also look at sexual history in adolescence and family medical history and geographic locations, because there are some things that patients maybe are more prone to in certain geographic locations, like Lyme disease. That's kind of upper United States area. Family structure, looking at that and how that can kind of play into the child's illness and life, okay? Health histories, this is kind of the same. So where did the family kind of come from? What environment is the child coming from? Do they have troubles at school? Do they have troubles with their parent-child relationship? Review of system, that's looking at the symptoms that fall within each category of body health systems. So like coughing, and that would fall under respiratory. Chest pain, that would fall under cardiac. So that's kind of looking at that review of systems. So, if kids say, yep, I'm throwing up, I have diarrhea, that falls under the GI system. So that's what review systems looks like. Dietary intake, knowing what they eat. Are they picky eaters? Do they have preferences on things? Are they overweight? Are they are they obese? Are they malnourished? Are they perfect and well nourished? So being aware of all of that stuff. Now, with pediatrics, you are not going to be able to likely go head to toe like you do with adults. You're just going to have to kind of roll with the punches and get what you can when you can get it. You know, it's best for you to get on the child's level while you're doing things. Kids get really scared when, you know, you're standing up over them. Let the parent hold the child if they want to. You know, I listen to kids, they're running around the room and I'm trying to listen to them as best I can. Always preparing the child. So trying to talk through, you know, in age appropriate ways to, you know, get them to work with you a little bit better, get them in the right position, maybe have parent hold them, doing the numbing cream, doing the distraction techniques, that sort of thing. Growth charts, we're always looking at growth charts. You're always going to do a height, a weight, or a length and a weight, because, you know, you want to make sure that that child's growing appropriately and getting enough nutrition. And if things are off, then, you know, you need to be checking into them or letting the provider know so they can check into them further. Pulses, you are going to do a radial pulse or an apical pulse. You do a radial pulse. Does anyone know at what age you can do a radial pulse? Starting at? It's okay if you don't. Okay, so at age 2, you can start doing radial pulse. From 2 and under, you should do apical pulse because that's most accurate. So listening to the heart. Obviously, you'll look at respirations. If they're working to breathe, do they have retractions? Are they nasal flaring? Are they tracheal tugging? Things like that. Getting a blood pressure, making sure you select the right blood pressure cuff. There are tons of sizes of blood pressure cuffs, okay? Putting it at the right spot, all of that sort of stuff. Looking at their general appearance. Are they happy, sad? Are they interacting with you? Are they not? Skin, all of that stuff. Lymph nodes, you can kind of look at that as you go. Physical assessment, you know, typically as a nurse, you're not necessarily going to be checking in their ears like a provider would, but, you know, you can take a quick glance at their ear, make sure it's not draining or dry discharge or something like that. Looking at their throat, their heart, their lungs, you know, listening to their abdomen, pushing on their abdomen, looking at their genitalia appropriately, okay? Anus, so I know that that's kind of an odd thing. Maybe you guys feel like that's on there. But, you know, there may be, there's, you know, in the infant setting, there are, you're supposed to use a rectal thermometer so you can check that their anus is patent, because there are some conditions that kids are not born with a patent. Head circumference, you know, looking at that in a cephalocaudal way. So from head to feet, okay? Is somebody unmuted? Does somebody have a question?
Oh, sorry, it's mine. My bad.
No,
I got
okay.
kicked out and then it rejoined, so I never muted
Okay.
it.
Oh, no, you're fine. You're fine. Ooh. Okay. So looking at the blood pressures, you know, making sure you're selecting an appropriate size cuff is huge. On the toddlers and you know, looking at the brachial artery like you would with an adult, but there's different places you can put the cuffs on kids. Same with adults, but typically, you know, you go to the same spot with adults. In assessment and management. So this is kind of the final chapter, the final section. So children continues to suffer if, you know, they're not adequately treated with pain. There's different pain scales that you can use, which we'll go into here in just a second. You know, they may not be checked as frequently as adults for pain because they're not as verbal about it. They may, you know, wait and not ask for pain medicine or kind of go a long time between pain medications. So you guys have to be aware of, you know, looking at your patient, knowing kind of their baseline, their pains being managed, and then kind of going from there to continue to monitor them, okay? So self-reporting scales. So kids that are older than 4, you have to use simple, easy words that they understand. So the FACES scale, that's probably the most common one, the Wong-Baker FACES. There are other scales on there, but really honestly, the one that I've seen the most is the FACES scale for this age group. So there's numeric pain scales, so like 0 to 10 scales, and those are typically utilized for kids 8 and older. Can some kids younger than 8 understand that? Yes, they can, but for testing purposes and things like that, 8 and older for numeric pain scales, so 0 to 10. And then there's also for a nonverbal child or for an infant, so 2 or less, 3 or less, you can use the FLAC scale, which that looks at their facial expression, their legs movement, their activity, their crying, and are they consolable. And then there's, other pain scales as well. And like I said, the FACES can be used, by preschool age children, but also a lot of times older kids kind of like the FACES because they can look at the face and the number as well and kind of understand a little bit easier how that correlates. We already kind of talked about the FLAC scale. That would be the most important one, I feel like, for you guys to know. So assessing acute pain. So, it's helpful for you as a nurse. You can kind of know what probably is going to cause pain for your child. So, if you have to get blood, put some numbing cream on them. It's really helpful. It makes things easier. If they have a tummy ache or a headache, give them some Tylenol or some Motrin. Motrin you cannot use in kids less than 6 months. And then sometimes kids with kidney involvement, you don't want to use it. But, don't be afraid to use those things. They really can help a kid feel a lot better. Obviously, if they're in a lot of pain and they're ill, that's going to make their kind of outcomes worse. But here's that Wong-Baker scale. So the FACES scale. So you can see it has that number score and also those faces, and kids you'll just say, okay, point to which one you're feeling right now. And, they're pretty honest and will be able to show you kind of where they're at. Now, some kids will be silly and point to ones because they think it's funny, but most of the times kids are fairly honest with where they're at. So obviously there's chronic pain, there's recurrent pain, and then there's persistent pain. So persistent pain is going to be something that you can't fix. It's always there. Okay. Recurrent pain is going to be, I keep getting these ear infections. So each time my ear hurts and it's worse each time, recurrent, over and over. Chronic pain, those are going to be the kids with things like potentially sickle cell or, maybe like cerebral palsy, they have pain, or muscular dystrophy, they have pain as well. So kind of that long for, greater than 6 months period of pain. So pain that persists 3 months or longer than the expected period of healing. So that's looking at chronic pain. So chronic daily headaches, that occur for a period of 3 months or longer than what the typical healing period is. Okay. It can obviously affect how the kids are interacting with their environment, their family, emotionally, socially, going to school. Kids that have chronic pain typically miss more school and maybe don't do as many things socially with their friends. So there's cultural differences in pain, kind of like we talked about earlier. Some cultures say, tough it out. You have a broken bone, you don't need pain management. So just being aware of that sort of thing, or there's, variations to that as well. So pain management. So there's obviously pharmacological pain management, which is like, Tylenol, Motrin, narcotics, things like that, which are used in kids too, especially surgical patients. But there's also non-pharmacological management, which can sometimes be more helpful than the pharmaceutical pain management. So relaxation techniques. So getting them to do some deep breaths, walking, telling them to picture their favorite place in their mind. That's kind of guided imagery. Swaddling babies, doing the non-nutritive sucking. So that is like you can put a passy in their mouth, and then there's it's called Sweeties. It's like sugar water essentially, and do a few drops of that while they suck on their passy. That can kind of there's been studies that have shown that that's equivalent to like the use of morphine. So something that's pretty powerful. So like when I worked on the floor, anytime we would draw blood on infants, we would use a passy and Sweeties. And then kangaroo care, that's what this picture is showing. A mom with her infant, breast or chest without clothes in the infant, and then you swaddle the infant up and keep them snuggled in. Some infants that are really sick, if you allow the parents to do this, a lot of times, they have better outcomes. So even something as simple as a parent holding their child can be a good non-pharmacological management of pain. Once again, pharmacological management. So Tylenol or acetaminophen, non-steroidal anti-inflammatory drugs. So like Motrin or ibuprofen, hot cold packs, PCA pumps. Those are something that are used in kids, older kids, obviously, because they know what their pain is and they can hit the button for themselves. And then epidurals, sometimes that's used in like back surgery kids and things like that too. So those are used in kids as well. So the transdermal analgesics, that is like the Elmex, that's the numbing cream that I keep talking about. That works wonders. You leave it on about 20-30 minutes, and then like I said, kids still think it's not going to work, but if you tell them to just pinch their arm where it was, they'll see that it works, and then a lot of times your blood draw goes a lot more smoothly, or IV start. Common pain sites for kids: teething, obviously vaccines, that's a huge cause of pain for kids. Painful or invasive procedures, so circumcisions or management of wounds, suturing, so doing stitches. Post-operative pain, so pain with surgical, they got their ear tubes, they got their tonsils out, things like that. That typically, you're using more of opioids and Tylenol or Motrin for that. And burn pain, that's probably the most difficult pain to control. You need typically oral medication plus topical like creams to help manage the burn pain. Recurrent headaches, recurrent abdominal pain, pain with sickle cell. Kids in sickle cell, they have crises. So a lot of times they have to go to the ER for opioid management when they're in crises. Cancer, obviously there's a lot of pain with cancer. And then, end of life cares, comfort cares, same like with adults. We can do that with kids as well. Okay, so which is a following factor for consideration and understanding the pain experience of children? Anyone know?
B?
B, is that what you said?
Yeah.
Yeah, exactly. So some kids may not admit that they're having pain, right? They might feel like they need to be tough for things. So that's something to consider, okay? Okay. All right. So that's the end. Okay, let's see. Well, I'm like basically right on time. So I've been recording this, so I'll put on my YouTube channel. I'll put that a link in the announcements. I'm going to stop sharing my screen so I can see you all. I'll put the link, I said announcements. I meant in that email. I'll just send back out the week 1 information. I'm sorry that you guys didn't get it. And I should send out week 2 probably by tomorrow afternoon time. Okay. So if you don't see week 2 information, like with the handouts and the PowerPoints, reach out to me. I can also try and figure out a way to put it in each module section if you guys would like having it in both spots. I can try and figure out that. It's just harder, I think, to put, like, I'm gonna have to do like multiple sections. It can't just all be in one coherent spot. But if you guys want me to put it both places, I'm more than happy to do that. What would people like? Both spots?
I think as long as we just know where we're getting the information from, we're not spending 7 days looking for it.
Yeah. Okay, I'm sorry about that. Okay, so definitely reach out if you can't find it. Don't feel bad for asking questions, but I'll get on here right after this and put all the information in there. Also, there'll be a Kahoots, which is like a review game that you guys can go through. I'm going to use that in the other lectures each week, but this time, since we had to go through the initial PowerPoint, we didn't get to review that. So that's something also that we could do in like open hours next week, my office hours, if people wanted to review before quizzes and things like that. Okay. So remember, quizzes information will be on the week following, or the week prior information will be on the quiz. Okay. Any other questions or concerns that you guys have at all?
I do have one last question. If for some reason we couldn't attend one of your reviews, do you send out the times that other professors are having reviews?
I sure can. Yep. Yep. And a lot of times professors do it, you know, right before or right after their scheduled course times. So, yep, I can totally let you guys know that. Okay. Any other questions or concerns that you have? No? Okay. All right, I'm gonna get off of here. I'm gonna send that stuff right now, okay?
Thank you.
Yep, you're welcome. Have a good day.